I will go ahead and reiterate one thing she said. We're fellow North Carolinians, so if I come out with a y'all or if there's things I say that you're not sure what word I said, just flag me down, or afterwards during the Q&A let me know. Before we get started, I've got a few questions that we need to go over, and then we'll begin after that. So if you will, you've got your controllers in front of you. I'm going to read the questions, the answers, then you'll have about 10 seconds to submit your answers. So please indicate how often you currently use each of the listed strategies with respect to navigating patients with lung cancer. Try to overcome barriers that I encounter through my role as a nurse navigator in lung cancer programs. 1, never, not often, sometimes, often, and always. Okay. Second question. Explain the role of approved and emerging treatment options for various lung cancer programs. So how often do we utilize these when navigating your patients? Never, not often, sometimes, often, and always. Okay. How often do you counsel patients with lung cancer in our lung cancer programs on expected side effects, symptom management, barriers, and transitions to care? Never, not often, sometimes, often, and always. Okay, so we're ready to get started here, and thank you for spending your afternoon or an hour of it with us or with me. I hope I keep you awake. I know it's after lunch and second day of conference, so we'll go ahead and get started. My goal today is to share my experiences with you as a lung cancer navigator. My ultimate goal is I hope that I inspire you in some way, that you get an idea from something I say, that you retain something from this that you'll take home and you'll use in your practice, and ultimately to benefit your patients and the families that you work with. This is where I work. This is Cone Health. This is Cone Health at Alamance Regional. Judy said Greensboro, which I am part of the Cone Health system that is affiliated with Greensboro, but I'm in Burlington, North Carolina, which is 15 minutes down the road. So the cancer center is actually just to your right. You can't see it, but it's not quite as pretty as our little wave that you see there. So this is where I work. It's the hospital is a 238-bed facility. I'm in the outpatient facility now. Prior to that, I worked in inpatient oncology for about 13 years on a med-surg/oncology unit. After that, I had worked night shift for about 9 years, and I decided that I wanted to be on daytime again. I never got used to it. It got worse. So I went to the cancer center at the outpatient facility, and I enjoyed it, but I wanted more autonomy, and I had a wise nurse manager at the time who said, how about the nurse navigator position that we were posting? It was for a GI and thoracic nurse navigator position, and I thought, I don't know what that is, but it sounds really scary. But I did take that position, and it kind of went from there, and it has morphed over the years to separate out the GI and the thoracic, and more recently to add a second thoracic navigator. So that's kind of where I've been and what I've done. I'm curious to know who is out here in the audience. Who are my nurse navigators and care coordinators, if you will? It's the majority of you, which I anticipated. Who are lung cancer navigators and coordinators? Awesome. I love being with nurse navigators, especially lung navigators, because I don't know about you, but at our facility, there's only a few of us. So opportunities to network and share ideas are sometimes hard to come by, especially lung specific. A lot of places, you're the only one. So thank you for being here. You see the resemblance? Knight in shiny armor with angel wings. So I don't know about you, but a lot of times you go places, you get questions, what do you do? What type of work do you do? And we all say we're a nurse because we're very proud of that. And then the next question is, well, where do you work? In the hospital or the cancer center. As soon as you say the cancer center or anything with oncology, people's heads drop or their expression changes. They look at you with pity and say, oh, that is so sad. That must be so hard. You must be a special person. And I don't know how anybody else approaches that, but I don't really like that because, I'm proud and happy with what I do. I don't think of it as sad. I love what I do. And so if I can, I try to avoid getting to the oncology cancer center part. But anyway, we brush that off. But what we do really is hard. It is hard work. I think about a patient that when I was a brand new navigator, I'd been doing it for, a few weeks, went into the patient's exam room with Dr. Choksey, one of our most experienced, or actually the most experienced oncologist. And this was the first consultation with medical oncology. And here's the patient, his daughters, 2 of them, they were late teens, early 20s, and his wife. And he did not know the extent of his disease. He had stage 4 lung cancer. And he just knew that he was referred there by his doctor because he had cancer and he needed treatment. Well, Dr. Choksey proceeded to let him know that stage 4 lung cancer was not likely to be cured. And within a nanosecond, his wife lost it. She fell apart. She's crying, bawling, like alligator tears. The daughters are trying to console the wife. The husband's looking scared, just like me, I think. And the medical oncologist says, oh dear, and turns and walks out. And this is a normally very articulate, prepared for anything oncologist, but it was, I guess, a bad day. So I was there. I didn't feel right leaving the room, so I was there giving that patient, his wife, and his family a few moments of silence and then trying to figure out what to say to help them put things back together and figure out where do we go next, what's our next steps, what do we do, how do we go on with life with this now life-changing event that's occurred. So that's what you do on an everyday basis. You go into these difficult situations. So this is you guys. This is your resemblance. You're superheroes because when you go into those rooms with the patient that doesn't know the extent of their disease or their prognosis, or maybe they've had reoccurrence, and this is not going to end well, and they're going to hear bad news. Walking in that room is something that most people want to go the other way. But you walk in there and you make a connection with that patient and that family. And that connection is your superpower because as a nurse navigator, if you're not connected, you're not navigating. So if you connect with that patient, that family, you're letting them know that wherever their journey takes them, good or bad, they've got a resource. You're right there with them. So be proud of yourself. Walk with the peace of mind of knowing that you do have superpowers, and even those bad situations, you are well equipped to handle them. Okay, so no surprise to anybody that's worked with lung cancer patients, or probably anybody in this room, but lung cancer can be complicated. There's no straightforward direction for lung cancer diagnosis, treatment, everything. It's all over the place. You never know the situation. You can't predict what's going to happen next or in what order things could happen. There are predictions, there's diagrams. Go through the NCCN guidelines. It'll take you a while to look at all the lung cancer ones. So that's why navigation is so important for lung cancer patients, because it is complicated. And that's where we excel, in making the complicated manageable, breaking it down into those steps where it is manageable. It's been well proven that nurse navigation helps with symptom relief, helps prevent anxiety and depression, better pain management, compliance with treatment. We prevent outmigration. We prevent wasting time on ineffective strategies often. You prevent ER visits and increase patient satisfaction. So it's well utilized. If we could, I want to do another poll right quick. It's going to be sorry. I think I skipped this one. This was a little bit back. Thank you. No, you're good. So if you'll have about 10 seconds on this one to pick your superpower. You already know what your primary one is, that of connection. But if you could have another superpower, what would it be? X-ray vision, invisibility, flight, time travel, super speed, super strength. Go ahead. This also tells me who I'm talking to. Gives me an idea of who your alter egos are. Okay, so we're all over the place. Not so many bodybuilders with super strength in here. That's good. Speed's good. Time travel. Okay, very good. All right, we're going to go right into the next poll. Sorry, I was supposed to ask you about your superpowers a little bit earlier, but that's okay. So, in your day-to-day routine of navigating patients, what do you spend a lot of time doing? Documentation, direct patient interaction, preparation for conference, gathering data, metrics, scheduling, putting patients in rooms, or something else? Okay, so documentation, direct patient interaction, those are both very vital, and I'm glad they're up there at the top. Let's see, okay, so we don't do much preparation for conference. I like that. Let's see, do a little bit of gathering metrics, which is vital. Scheduling, okay, very good. So this just illustrates how many different ways there are to navigate. You know, those colored pencils are just probably a fraction of the ways there are to navigate. And yes, there are a lot of navigation roles that we want to make them consistent. And there's a lot of efforts out there to make, expected norms. However, you've got to navigate to your population. You've got to navigate to your facility, your hospital. If you're in a rural area or in Philly, your navigation is going to be completely different. Your barriers are going to be different. Your resources are going to be different. So you've got to navigate to what you've got. You've got to navigate to the people that you've got. The patients, ultimately, you've got to navigate to what their specific barriers are and figure out the best way to do that in your location and with your resources. So that's always going to be different. I'm very biased to a very hands-on, direct patient navigation, meaning I want to be in the exam rooms with the patients while they're getting the bad news, while they're getting the good news, while they're getting their treatment options. I want to be there when they go see the different physicians. That's just my bias because that's my experience. I'll talk a little bit more about that, but first I want to tell you about a patient that I worked with some time back. Her name's Bonnie. And Bonnie was a challenging patient. First time I met Bonnie, she was at our center for her initial thoracic surgery consultation. She, before I walked in, the nurse that roomed her told me, this patient's a little tough. She doesn't want to hear the word cancer. She doesn't want to know if anything's wrong. And she's here to see the thoracic surgeon about a lung mass. Okay, so we go in the room, and there with the thoracic surgeon who's stumbling over how to communicate with her and doing the best he can and does a very good job. But Bonnie was 60-some years old. You could tell her clothes were very clean, very neat. You could tell she was very proud of her appearance. At the same time, you could tell she had very meager means. She had disparities. You could tell that by her appearance. When she smiled, which wasn't very often, she had kind of a poker face and looked at you with a lot of distrust. But when she did smile, you could see she had a couple of gold teeth, a lot of missing teeth. And you just knew that there was a long story behind Bonnie's life. So Bonnie went on. I developed a very close relationship with Bonnie. I worked with her a lot. She talked about where she lived. She was proud that she managed her home herself, but said it was in a really bad area, bad neighborhood. It was on Gunn Street, and so that always said, okay, I'm staying away from Bonnie's house. I will see her in the clinic. But anyway, Bonnie and I had a very good relationship, and she went on to be diagnosed with a stage 1 squamous cell lung cancer and ultimately got SBRT, stereotactic radiation treatment for curative treatment for her lung cancer. And we'll talk more about Bonnie as we go forward. So, does everybody in here have a smartphone? Who doesn't have a smartphone? Raise your hand, please. Okay. Maybe you have one. I won't call you out. My parents don't have smartphones. They have flip phones. They love them. They don't want a smartphone. Do all of you remember what it was like, or most of you remember what it was like before you had GPS or a smartphone, and how hard it was to go from one place to another if you've never been there before? You had to ask directions. You had to stop and ask directions multiple times usually, right? If you wanted to communicate with somebody, you had to wait till you got home. This was before cell phones, which a lot of us will remember that. You had to wait till you got home to call them. You couldn't communicate instantly. You couldn't text them. You couldn't message them on Facebook. So before navigation worked with lung cancer patients, there were a lot of problems that were not addressed because you had to wait till you got home to call. You had to, getting from point A to B was not easy without a guide or a GPS or a navigator. So what we do is be in the smartphone, be in the GPS, connecting our patients with their next visits, their plans, being the person that they can pick up their phone and call when there's a problem. We are that resource for that patient. When I first started as a nurse navigator, Dr. Gittin came up to me and he said, if you had a piece of paper, and he placed a piece of paper on the counter in front of us, he said, and you had to get it from here to over here, how would you do that? And I picked it up and moved it and looked at him like he was crazy. And he said, you're going to be a great navigator. So it takes a little bit more than that to be a great navigator, but ultimately it's a science, it's an art, it's a little bit of everything. One of the things that we all have to do is find our patients. You've got to be good at your EMR, whatever that is. You've got to be good with connections. You've got to, for me, that meant, connecting with our scheduling people, connecting with, making sure I knew how to search our EMR, make sure I knew how to search the EMR for our pulmonary doctors that were not in my clinic, because I wanted to know if there was a patient going there that I should be involved with. Knowing how to look in the hospital and see who was admitted with a lung mass. Maybe they didn't have an oncology referral, but I wanted to know because I wanted to go ahead and get into their life and make a difference moving forward and make their transition from inpatient to outpatient care easier, smoother, more comfortable. So you've got to find your patient. Once you find them, you've got to do your homework. You've got to know who that person is inside and out. Look at their past medical history. Look at their notes from their primary care, from their other physicians. Look at their comorbidities. All that's going to paint the picture, and you all probably are so adept at doing this, you do it without even thinking, but this is important that you know your patient. Once you find them, you got to track them. You got to be like that hound dog there, and once you get the scent of them, you got to know where they are basically at any given time, especially when they're in your clinic, so you can pop up like a ghost right when they're getting ready to go in with whichever doctor they're seeing. You've got to, you've got to know where they are at all times, and watch for changes because there's going to be changes. Your doctor's going to have a cancellation and they're going to move your patient up that you were going to see at 3 o'clock. They're going to be seen at 10 o'clock and you may or may not know about it. But you've experienced all that. So you've got to know where they are. You got to track them. You got to track their follow-up appointments so that you're there at the key appointments that you want to be there for. When you make contact with your patient and say, I'm a nurse navigator, not many of them know what you are, what you do, or why they need to know you. And they're already overwhelmed in the cancer center, and one more person is the last thing they want to have to deal with. So my normal thing would be I'm a nurse navigator, and that's just a fancy way of saying that I'm a resource to you for as much or as little as you need me. And then I'm kind of in the background, and we both see what the doctor has to offer that day and go from there. But you've got to connect with that patient. You've got to make that connection. That's your superpower. Okay. Working behind the scenes. So you've probably heard the story of being like a duck. You're on the water, you're going against the current, you're just cruising so peacefully and calm. Well, that only happens because the duck is paddling like hell underneath. So behind the scenes, you're working your tail off to make sure that there's no problems coming up, that patient's authorized for their PET scan, that their PFTs are scheduled at the right time before they see the thoracic surgeon, that they're getting in for their SBRT consultation, that their biopsies are moving along, that they're not getting delayed from surgery for their cardiac clearance that should have been thought about weeks ago. You're working behind the scenes to prevent problems and eliminate barriers before they even become barriers. So I'm going to tell you a little bit more about my specific navigation experience. My start is from suspicious finding to treatment start. There's different ways, like we talked about. to navigate. My bias is for this. This is the way my program was designed before I ever started being a navigator. It was identified that this is a critical component or critical time where navigators are very vital because there is so much information, so much complication, so much chaos for a patient with a new diagnosis that a navigator is key. Once they get to treatment start, I tell the patients, you may not see me at every appointment, but know that I'm always available if you need me. But that patient is seeing the nurses in radiation oncology, they're seeing the medical oncologists, nurses, they're seeing their infusion nurses, they are connected to resources when they have a problem. So that's why it was identified for me in our practice that it was appropriate to back off at that point and kind of follow along in the background and know that if that patient had a reoccurrence, I could be called to jump back in to help them through those difficult times, or anytime the patient needs me, they could always give me a call. Being present for the initial consultation, the initial appointments, like I said, that's my bias, is to be there if you can. A lot of you may be in health systems where the volumes make this impossible, and so you do the best you can to be there, whether it's even just a phone call following up on a missed appointment, because you can't be in multiple places at one time, so sometimes that happens. But the ability to connect with that patient, be there for their appointment, to be able to translate, to be a translator for that patient, whether it's truly a language issue, maybe your physician speaks a different primary language than your patient, and even though they speak English, the patient may not understand that. Maybe they're not from where you are and they speak and say y'all and things like that, and the patient doesn't know what you're saying. So being able to translate language, be able to translate cultural issues, being able to translate and summarize what the physician says after the physician leaves the room and describe this is the plan of care, A, B, C, D, and write it down legibly for the patient so they know. Or be able to be a resource for that patient. Once they get home, they tell their family, and their family wants to know what's going on, so that you can explain what's going on to that patient. That helps you let the patient know they're not a number. Because isn't that what we all want? We want to know if you're a cancer patient, you're not a number. You know, you're a person, and these people care about me from a personal perspective and not just because they're one more patient or they're a lung cancer patient. So it lets you connect with them, and it ultimately lets you empower them to make their decisions, because that's also what we want. We don't want to do what the group of physicians recommended. We want to do what's right for the patient, but we want the patient to be informed. Your coordination efforts. I can't say enough about coordination because we all do so much of it, just like I was talking about. You're preventing barriers. You're going to the schedulers and saying, well, I want the PET scan tomorrow, I want the PFTs the day after tomorrow, and the consultation with this doctor this day. And then when that happens, great. When it doesn't, you're on the phone trying to work something out with the PET scan department. Don't you have room to add somebody on? This is really important. This person likely has a small cell, and we can't wait till next week. You know, these are all things that you do that are very important, and they do impact patient outcomes. Being 10 steps ahead. I can't overemphasize that, excuse me. Being 10 steps ahead is so important so that you are anticipating the next problem that this patient will face, the next barrier they will face. You're anticipating it before it gets there so that you're responding proactively and not reactively. You can't always do that, but the more we can be ahead, the better off we are. Being aware of transitions, because those are points where things are going to change. The patient's boat gets rocked a little bit. You've got to be available and ready to help that patient. Remember, your superpower is connection, so you're going to continue that on through this part. And communication, if you have another superpower, it's communication, because those two go hand in hand. You can't have one without the other. All right, is this kind of scary? Some people that I work with, I showed them the slide, and they thought that was kind of scary. So, does anybody get direct reimbursement for your direct patient navigation services? If you do, give me a hand. Okay, and I think that's how it should be. That's another topic for another day. Anyway, because of that, a lot of us are sometimes, especially a new navigator, are very concerned with job security. And people that are concerned with job security are very willing to please. And as a nurse, you are born to take care of problems. And no matter what it is, it doesn't matter whose job it is, you take care of it because you're a nurse. And we're used to doing that. We're used to being resourceful and problem solving. We don't, ask for help unless there's no other options a lot of times. So it's very easy to become victim to something called scope creep. That's what this is. This is scope creep. So At some point during your navigation experience, somebody either has or will come to you with some duties that are very important, but they are not patient navigation. And how you manage that is important, not because you're lazy and you don't want something else to do, because I've not met a lazy nurse navigator yet. You know, nurses are human, and sure, there are some nurses that are more motivated than others, but I'm sure there's some out there somewhere, but I've never met a lazy nurse navigator. I don't think we come to this position because we don't want to work hard for our patients. So the reason you advocate for yourself for navigating patients and not doing things that are not truly navigation is because the less time you spend with your patient, the less you're able to help them through the journey, and the less effective as a navigator you are. So, you know, that's something you have to continually work for. The support of your administrators and your physicians is vitally important. That will help you more than anything, is having them on board, having their support. There's always exceptions. Remember our friend Bonnie? Bonnie was an exception to every rule, and so she, like I said, got her treatment for her lung cancer. She was a hot mess. When she was there, our little 90-some-year-old lady at the front desk that checks people in and answers the phones, Bonnie'd look at her sideways, call me over there, say, look at her, she doesn't like me. She's mad at me. I said, Bonnie, she's the sweetest woman you ever met. She's a little grandmother times 10. So, and then Bonnie, certain people were the only ones allowed to draw her labs or to give her infusions. And we had to deal with some of those because some of that's not reasonable. And we had to bring some reality to Bonnie. But she would threaten to walk out. One time, I remember getting called to the lab waiting room because Bonnie had threatened another patient. The patient looked at her wrong and was looking down on her. So Bonnie had some undiagnosed psych problems, I believe. That's never been proven, but that was my belief. But it didn't matter. We still needed to help her through her journey and help her receive the best care that she deserved and that she could have. So Bonnie had a thyroid issue that we identified when we did her PET scan from her lung cancer that we diagnosed. And after her SBRT, we decided it was time to have her thyroid evaluated. I ended up going with her to her ENT appointments to have her thyroid evaluated because that's the only way she would get there. So that wasn't really lung cancer navigation, but it was important for her that I did that, so I did that. So barriers, let's talk barriers. We're going to do our another poll right quick because I'm interested to know what barriers you see. I have a feeling they're going to be very similar to what I see as well. So what are the most common barriers you encounter? Are they financial, transportation, knowledge, family dynamics, anxiety, or something else? Okay, so financial's a biggie, transportation's a biggie, knowledge is a biggie, not so much family dynamics, anxiety. Okay. There's not a lot of others, so that tells me that we're on the right track, that we're seeing the same things. So barriers, that's like if there's a definition for navigation, it's barriers, right? I mean, that's what we do. We eliminate barriers, eliminate the effect of disparities on patients so that they can get the best care that is possible for them to receive and come through it hopefully as emotionally intact as possible. So I'm going to talk a little bit more about Bonnie. She had every barrier known to man. She never got her thyroid biopsy because while we were in the middle of working that up, she felt a lump in her breast. She proceeded to have triple negative breast cancer, surgery, radiation, chemotherapy. So we had a lot of barriers. Patients with disparities have more barriers than most. Bonnie needed transportation to every appointment. She never had a support person with her. Never met anybody else in her family. She didn't want to tell her family. She didn't want anybody to pity her. She was very religious. She loved her church family, but she would not tell anybody at church because people talk. So Bonnie had a lot of anxiety. A lot of people have trouble. Anxiety goes with cancer diagnosis. It just does. People come to their diagnosis with pre-existing anxiety, pre-existing depression. All these are barriers to care. They cause delays in care. Delay in care or prognosis. So the more you can do to eliminate these barriers, the better your patient's going to do. Family, family dynamics, that can be a big player, even though that wasn't a most common barrier, and it probably isn't a most common barrier, but if your patient is caring for another family member, a special needs child, if they have young kids at home, if they have an elderly parent, if they're caring for someone else, that's a big deal. If there's so many things that with family dynamics that can throw monkey wrenches into your best laid plans, where you're laying out this tomorrow, that the next day, and this the next day. Oh, well, I've got to take so-and-so to the doctor this day. I can't do it then. I got to pick my grandchild up from school on this day. I can't do that then. So it's a big deal, and it does matter. These barriers are important. And as far as the financial barriers, I probably don't need to mention that because we all know that's one of the biggest ones. But looking at your resources, as far as financial barriers go, if you don't have the money to adequately feed your family, if you're looking at a foreclosure or being kicked out because you can't pay your rent or something else, you're not engaged in your treatment and you're not going to cope as well with your treatment. So that's a big deal. Barriers, the biggest thing you can do is know your resources. Different facilities are going to have different resources. Bigger academic settings likely have more resources, more funding, more options. Your rural areas, it may be more limited, but there's still resources out there. Look into your community resources. Maybe your hospital doesn't have them, but your community might. Look at your faith institutions. Look at your churches. A lot of your churches will help people in different ways, whether it's financial, whether it's with clothes for their family, whether it's with rides back and forth. Look at your state-provided transportation. Look at all these different options and be adept at utilizing them for our patients. And the ones I'm familiar with working with, we're a community cancer center, but we have a lot of resources. I've got a social worker that I work hand in hand with. There's counseling options. Look at your dietitians can assist you. There's a lot of funds that are available, so just make sure you know what's available to you for you to utilize for your patients. So, not trying to insult anybody with statistics, which we don't like, or numbers and this and that, but I do want to give a brief update with lung cancer and where we're at. So, these are some 2019 updates. Our lung cancer rates are down, which is good. They've been down for a little while. And that's likely due to people smoking less, which is another good thing. Is there anyone here from Boise, Idaho, Richmond, Virginia, Baton Rouge, Spokane? All right. These places, these cities are their population is about equivalent to the number of patients that will be diagnosed in this country with lung cancer this year. All right. How about Syracuse, Waco, Texas, Charleston? All right. These places are equivalent to the 2019 lung cancer death rates. There are hundreds of thousands, and like I said, I don't like statistics, so I think about the population of a whole city. That's a big deal. Anyway, I don't need to tell you that. You all know that. So let's talk about funding. Funding for lung cancer. It's historically not been equivalent to the societal burden. Lung cancer by and far kills more people every year than any other cancer, but the funding is nowhere near that. So we have to keep advocating for that, for our research, for our patients, and the funding that will bring about improved outcomes. Our to-do list, if we have one, to change some of the general lung cancer numbers and how serious this disease is, or how deadly it is to, first of all, get rid of the stigma. It's been around forever. People did it to themselves. Some of us are guilty of thinking that at times. I've had other nurses come up to me and say things about patients that had lung cancer, basically saying they did it to themselves. And that just breaks my heart, because does anybody in here like cake? I should have two hands up. Ice cream. I mean, you eat these. None of them are technically good for you, but you eat them because you enjoy them. People that smoke started smoking not because they wanted to be addicted or because they wanted to harm themselves. They did it because other people were doing it. They did it because once they did it, it felt good. It made them feel good. They got addicted to it. It's human nature, unfortunately, to do things that make us feel good. And that's another talk, but nicotine's really good at making us feel good. So if we've got to get rid of the stigma, because the funding disparity goes along with the stigma. And a lot of people get lung cancer that never smoked. And so you see the 81 up there, that's the percent that are related to smoking. Well, if you take those hundreds of thousands of people that will lose their life from lung cancer and you do the math and find what 19% of that is, that's a really big number. And those are people that never smoked. So it doesn't matter what brought somebody to where they are today. If they're a lung cancer patient, they're a lung cancer patient. And they do deserve our ultimate care, and there's no stigma involved. We've got to increase funding. I already mentioned that. Increase attention to lung cancer, because the more attention we have to it, the less likely people are to start smoking or continue smoking. We've got to increase the smoking restrictions, not because we want to pick on people and make them feel stigmatized further, or because we want them to, feel like everybody's down on them, but because by having stronger restrictions, you're going to limit secondhand smoke, you're going to limit a little bit of firsthand smoke, but more importantly, you're going to limit the influence that these people have on their kids and on somebody else's kids, because people don't start smoking in their 20s usually. As part of my lung cancer screening work, I talk to people all the time about when they started smoking, because nobody's honest about how many years they've been smoking. And that's not on purpose, that's human nature too. So you say, when did you have your first cigarette? It's always as a teenager. Sometimes it's younger than that. So the influence of seeing adults that they look up to that are smoking is big and can't be overemphasized. We also have to do more lung cancer screening. We've got to look for it early so we can catch early and we can cure it. So this leads us right into our next topic here. Why do we screen for lung cancer? Is there anyone, who's familiar with lung cancer screening? Okay, wonderful, perfect. So this is a patient that I worked with when we first started our lung cancer screening program, and you all see that pretty lung cancer there on the left side there, or left lung. And I'm happy to say she got surgery and was cured. I speak to her every 6 to 8 months or so, just checking in on her, and she's doing great. So that's why we do it, to find lung cancer early, because without lung cancer screening, you only find it early 16% of the time. That leads to poor outcomes. I'm going to go back for a second because I failed to mention something. That 19.4 is the 5-year survival rate of all lung cancer patients. The 60 to 70 is the 5-year survival rate for all cancers. So that's another illustration of the difference, which you're all very well aware of, I'm sure. So that's another reason why we do it, because if you find it early, well, your survival rate goes up to 56%. That's getting close to that average. That's a lot different than 19. So that's why we do it. I don't need to go into probably the details of